I've been really excited for this, and combination of excited and nervous, where you think it could be really game-changing, and now we have to make it game-changing. So that's the nervous part. I want to just walk through a few rules of the road, just so you know the rules of the road, and we know the rules of the road. So the first rule of the road, we've already broken. Never have 5 people on a panel. So don't ever do that. So as part of that, if we can just be succinct as much as possible, and we will use the ejector seats if necessary at some point. Second rule of the road, never do an interoperability panel right after lunch. So that is another one we have just broken. We'll make sure we keep this interesting, though. I promise you this will be interesting. And as part of that, one of the rules is we don't have to have everyone answer every question. I've been on panels where what happens is the fourth person says, yeah, what they said, and then they say the same thing for 3 more minutes. So the roles were really good. If you have an extra role, you can chuck one up here if that happens. But please chuck it at me, because that means I have not moderated this very well today. Also just fair warning, I may pull on strings of things that you say. So I know we've have questions we've thought about. I actually don't know what their answers are, so this is not one of those panels where they've already rehearsed to me all of their answers, so I'm going to be as surprised as you with whatever they have to say. So we're going to be in this together today. And last but not least, we're going to try to leave 20 minutes at the end for questions. We welcome whatever questions you have. If they're tough questions, we'll give them to Sam at the end from Athena, and he will answer in Italian. Because I learned today, he and I both speak Italian, and of all the languages to speak together, that is the least likely, it feels like, to speak. So, okay. So those are the rules of the road. I want to jump in, and I'm going to just share 2 quick thoughts. And while I do that, here's how I'd like you to introduce yourselves. If we can go down the row, starting here, with who you are, where you're from, and just 1 or 2 sentences about your why. Again, we have not prepped this, so Mike's like, what the crap? I did not know this was the deal today. Give 1 or 2 sentences about your why. There's not going to be a slide about how big your vendor is or how many health systems you have, which feels like a kind of a necessary slide that we're just going to skip today. So one of the things that we got this morning was the art of the possible. I think the points of light were really, really interesting to just see what could be done. And I don't know if you're like me, you're anxious for the next chapter of okay, so you're 11 months in, or you've done this much, what happens with the next chapter? When we started looking at the points of light a few years ago, we thought we would have dozens and dozens of things to sort of choose from. And it turns out we found about 10 points of light when we started this in the early days. And that was looking under every rock. Didn't feel like there were just that many real meaningful payer-provider true collaborations. And I was thrilled this year that we had 25 meaningful. And by the way, that meant there were other ones that did not make it on stage that we thought were interesting, but maybe not quite as meaningful. So part of our panel today is going to be talking through what is not, why is it not working as well as we'd like it to? What can we do as pioneers to get there to make it work? And we'll just see where this goes. So Dan, if you can start for us with who you are and 2 sentences on your why.
Nice to be with everyone today. Thank you for having me. Dan Wilson from Moxie, based in the upper Midwest, so very nice to be down here. My why is that I believe we're kind of on pathway to bankrupting the country because of what we spend on healthcare, and I feel it's a total imperative to do everything I possibly can to bring down the cost of healthcare in this country so we can make sure we have healthcare available to everyone in this country.
Thank you. Mike?
Sorry, I couldn't find a microphone. Mike Cadero, I from Meditech. I'm from Massachusetts. In the why, and the why. So one of the missions we have at Meditech is supporting our customers is to make sure that we're supporting them in a way that they can maintain their independence. And one of the ways we do that is to remove data fragmentation and enable interoperability. So that's my why.
Great. Sumit.
Hi, folks. I'm Sumit Rana. I'm a computer science guy by background, work at Epic. And I think my why ultimately is to help patients get cured and have healthy lives. And in order to do that, providers need to take care of them. And in order for providers to do that, they also need to get paid. And so we got to make sure everything works well.
Thank you. Sachin.
Yep. Sachin Patel, President and GM at Datavant, and based in Southern California. And my why is, prior to getting into healthcare technology, I actually worked with a value-based care oncology group that was based in primarily rural settings. And I grew up in a rural environment myself in Texas. And so wanted to see and learn how we could use technology to make that experience more easy for those sorts of practices, and generally speaking, so that they can be sort of viable enterprises.
Great. And Sam.
Yeah, hi. Ciao. I'm Sam Lampson from Athena. My role is to broker the relationship between our Athena practices and the rest of the world. So really creating that layer of interoperability. And my why for this, and why I've done it in this company and at the company I was at before, is because I have had personal friends who did not make it because the doctor didn't know things that were known about them. And I think that is just a travesty about this country. And I think some of these problems are uniquely this country. And this is a group that can help solve that.
Great. Thank you. And by the way, at some point, I'd love to hear your whys, because as I've met with a lot of you, I know you have passions that come from very specific activities that drive you. And by the way, one of the things I don't want to have happen today is have you feel like class is letting the vendors off the hook. Because these vendors know when we come, we try to hit them between the eyes with the feedback on what they can do better. That is not the goal of our session today. In fact, we're going to talk about some things that are outside of technology, of how we actually make them successful. And that's where I want to start, is what is keeping us from having more success? We had these 25 points of light today, a lot of really cool success. There's a lot of failures as well. We did not invite them to necessarily come speak. Maybe that's next year, of what not to do. But if technical barriers were eliminated tomorrow, what organizational dynamics would still prevent interoperability from advancing? Who wants to start us off on that one?
I can go. I have a
Great.
19-point answer.
Great. Ejection chair is ready.
That's one way of getting out of this panel. I will sort of hit maybe 2 or 3 points, and then I'm sure others will sort of jump in with others too. I think one is, Jocelyn, I don't know where you are. You did a great job this morning. I thoroughly enjoyed your presentation. And one of the things you mentioned was how, the organization may be one organization to the outside world, but behind the scenes it may be 10, 15, 20. And those 20 organizations might have 20 different systems, sometimes 50 different systems. And you have to connect to the last mile on each of those systems before you can take what's possible and make it ubiquitous. So I think that's sort of one challenge. And it's not just technical aspects, it's the people side, it's the process side, it's the priority side. I think the second one is, I'm going to just quickly mention, is sort of the reimbursement models. I think we're largely still living in a fee-for-service world, and the way you do this for that is just different than the way you would go about doing it and retooling it for value-based care. And then I think the third one is that I'm not here to justify why it exists, but I do think there seems to be a lack of trust, and there seems to be fear that if the other side gets my data, maybe they can utilize it in a way that gives them an upper edge. And so timing becomes an issue, and I really loved how you framed it this morning, Adam, that we're going to have to just take leaps of faith together.
Yeah, sorry.
Building off of that, one of the things that comes to mind is the time horizon that we all work on. And so I think we have the luxury of many organizations being nonprofit, which you would like to believe means that we're investing for long term. But in practice, many people are investing on a quarterly basis. And so we end up taking a very incremental approach to investment decisions we make, the technical improvements that we make. And I think that continues to hold us back quite a bit. And so anything we can be doing to create kind of a new cultural approach to saying, what are, if we're taking this leap together, how far can we leap? Because we're really thinking about where we're trying to get to and getting there in as few steps as possible.
Yeah, I think just piggybacking on that, there's like a lack of education. So there might be the large provider systems out there that have the bandwidth and have the technical capability and the understanding big picture how maybe data interoperability or data sharing is going to change workflows and reduce burden. But there's this constituency of health systems that are in the community, that are smaller, that don't have the resources, and sometimes I'm having conversations about why you need to do this and what that will gain you. So as it relates to kind of this payer-provider data sharing kind of paradigm, I feel like a lot of times I'm educating or trying to sell on why we should enable provider data sharing. And I feel like some of that responsibility around that education might not solely just be on the vendors that are supporting them.
So let me pull on one of the words that was used here, and that was fear. I think there's a very real fear of data being used against us in whatever manner. I mean, we could talk about a lot of specifics, but any thoughts on how we specifically decrease the fear? Trust cannot be given, it's earned, really. So how can we prove it? How can we earn trust? Any thoughts on how we can decrease that fear side?
Yeah, I can add a couple thoughts on that. I think the way to do that, and I think it's the trust and the fear thing together almost, right, between payers and providers. And there's mechanisms now, I think, with all of the sort of technologies that are represented here on the stage as well as like throughout the room that can allow you to build that trust through an interface that allows both parties to see exactly the source of that data and why a certain decision is being made, and then you can adjudicate, left, right, or center, or whatever, decision you want to make, but at least everyone's looking at the same source data. So I think that is an important part of this. And then secondarily, I think, just as is often the case and in some of the presentations and the breakouts, you want to sort of do the, crawl then walk thing and start with areas where that there's really good fidelity of data and exchange of information. Say, okay, let's arrange a concept or a contracting structure around that, and then go from there to make it broader versus trying to go for the entire population, and you inevitably end up with sort of a distribution curve of different conditions or whatever it may be that complicate it, and then you sort of immediately erode the trust almost, substantially or fully.
Yeah, I think just building off of that, I actually don't think the fear is misplaced, unfortunately, because there are still too many examples where we collectively benefit from asymmetric information in the system that we have set up today. And asking people to eliminate that is fundamentally going to be scary, particularly if the underlying system and incentive structure isn't changing alongside. And that's why I think we only have a couple of use cases that we talk about, because these are the ones where incentives are aligned enough that both sides can benefit, and we can overcome what is, I think, a foundational lack of trust. And so, we probably will all echo it, and I think most in the room would agree that in the absence of trust, transparency is the best thing we can fall back on. And then it becomes a question of how do we embrace a model where it's limited auditing and limited, that people are not abusing the system, so that over time we build more default trust.
Yeah, if I might just add one more, just building off of what everyone said, is getting to the clarity of purpose and what we're trying to achieve creates a lot more alignment than just saying, I want the data, get me the data. These kinds of conversations we've all kind of observed, and they don't go anywhere, whether it's, groups coming together or individuals putting pressure on others to get data. But when you start talking about, hey, here's the overarching, goal that we're all trying to achieve together, and here are the use cases specifically that we want to go achieve, and here are the mechanisms whereby we would, and create a system that works to that end, I think that's when we see a lot more success. And it takes, to Mike's point, more education, more cooperation, but in the end gets us the outcomes that we're all kind of looking to achieve.
So we've talked about having, if we're working from the same data, it's a beautiful spot to be. You talk about the data asymmetry, and that gives sort of a power to one side or the other. How often do you feel like we're actually working from data symmetry? And how can we get to, any thoughts on how we get to just more moments of data symmetry? Sumit?
Well, I will first say that, I've talked to sort of CEOs of both health systems and of payers, and I sincerely mean it that I don't think this is an issue of will. I think they truly look at it and say, boy, we got to do better. I do think there's a lot of, first of all, details that need to be sweat. Anytime you want to couple two systems that have a whole bunch of downstream that happens on both sides, it's not just merely a function of tossing the data, right? Like the impedance has to match across the entire workflow. Otherwise, you technically have data. I mean, why do people use faxes still? We all hate faxes being used in healthcare. The reason they use is because very low impedance, right? It's like, here's the stuff I have, here I tossed it over to you, now have fun with it. You have the data, technically, but unless it sort of conforms to what's going to happen on both sides, you can't get it to actually achieve the goals we need to. So I think that is a part. I'm not as closely involved in this as two of my colleagues here are, Kevin and Karsten. So, but they can sort of allude and talk about the thing that one of the things I've done personally is I've actually met with our teams on a weekly basis, and I've said, "Tell me what failed this week. What was it specifically?" Oh, the addresses didn't match. Actually, turns out it was that in one system it said the address for the provider said Madison Street, the other one said Madison ST. Okay, now we can fix that. You go to the next thing. And there's just things upon things like that. Sometimes is that, we send 30 things as part of an attachment, and on the other side we can only take 10. Okay, once you learn that, then you can break it into 3 transmissions of 10 each, and you can solve that. So I think that's an important thing that needs to be done. I completely agree with the transparency thing. One of my favorite quotes is that trust and communication rise and fall together, and transparency obviously happens once you have communication.
I think we kind of know the answer on some level to your question of how do we have more symmetry. We have to define use cases tightly enough that we can speak to the value to all stakeholders, and we can have more of a common language of exchange. And there have been so many efforts at that over the years that continually fall short, because I don't think there's ever kind of a destination we're going to get to where it's job done. But the more that we can continue to embrace this idea that expands areas of economic alignment, so that we can find more and more use cases where we can articulate the value to all parties, and then we can have an honest conversation about what data is required at that intersection to facilitate, kind of a fair exchange. It's just the hard work we have to keep doing. So, great, we all started with risk adjustment. We knew that was a good use case, and there was a lot of economic value. And then we go to quality, and then we go to payment integrity, revenue integrity. Like, what is the next, prior auth? What comes next? How do we get attribution to work finally? Those types of things.
Yeah.
And if I could,
Please.
not to run afoul of the guidelines here, but really quick, and my mind was in the same spot as Dan when he first mentioned the sort of, there's 2 cases that we all have agreed that there's aligned incentives, and so you have symmetry of information, and risk adjustment is one of them. I think another model to think about and is the revenue side of the equation typically seems easier to solve for everyone and get aligned on, right? I'm overly simplifying. The cost side of the equation, whether you're a health system, a provider that's in sort of few clinic setup, or a payer, is who's left holding the bag. Not to again oversimplify it, but that's part of it, right? That's the asymmetry. And so I think that the promise of value-based care, MA sort of pressures aside currently, was to try to solve that cost side of the equation, right, and align those incentives. So I still think that absent another model, that approach or the spirit of that is what can help to increase some of the sharing of that information. And you do see it in practice in some of the more sophisticated markets where you are saying, okay, how many patients receive this type of chemo versus that type of chemo, and you're openly talking about that in particular pockets of populations.
So it's interesting. I think for years on this front between payers and providers, there has been a technical challenge of how do we actually move the data and how do we get everything where it needs to be. I feel like now that keeps getting less and less of an issue every year as the tools get better and better. But yeah, we still don't have probably adoption that is symmetric with the improvement in the tools. So not letting you off the hook, that you need to keep improving the tools. What can the payers and providers do to move beyond kind of overemphasizing the lack of tools and move forward, jump? And I know some of these questions are similar, but like, how do we jump? How do we go move that way?
Well, I think it goes back to what you originally said, is understanding the goals, the objectives, and kind of having alignment around, hey, we need to do this to achieve a specific goal, and then both organizations work toward it, because it's not just enabling an interface or an API to share data. There's a lot to do with respect to the data itself, and am I collecting the data in an appropriate way? Is it codified? Does it make sense? And that work in itself can be a lot, right? Because Epic might, store data in a format that's completely different than Meditech. It might be codified, it might be the same data, but there's nuances that kind of make it a challenge to share sometimes, and there needs to be work to kind of change that. And it goes back to the health systems having the capability to do it. A large health system, yeah, no problem. There's data scientists, there's folks that have the tools to do that work. You go to a community hospital who has an IT staff of 5 that wear many hats. Well, they're less sophisticated and less probably able to put the human capital in to kind of get the data and the use case in a way that it needs to work.
So before we get to the next answer, I just want to drill down on that for a second. You're right. If you talk about, like, Cleveland Clinic came up 3 times in like our room just being referenced, they can do a lot of stuff. Yeah. If you talk about a community Meditech hospital, do you think there's a hope for them to be able to do this in a more simple way?
And that's something that we're working toward. And I'm sure AI came up this morning a little bit. And how are we leveraging technology to help codify that data? How are we leveraging technology to prepare it to be shared, et cetera? And that's what we're looking into. That's what we're working on. But as you deploy technology, there's a cost there as well. And again, it goes back to, is that something that we can pass on to our customers? Probably not. Some of them are really keeping their lights on. So I think it's a balance, and we're trying to figure out where technology can kind of help get us to a point that we're not interoperating efficiently, but it's a balance.
I think Mike hit on a lot of, I'd almost summarize as there's a capacity and there's a desire that go into accelerating this, right? And there's all the technical pieces that we're talking about, but I think there's this very large cultural piece as well that we need to discuss. And so, for an organization, there needs to be time to actually, and the point was made this morning, I think, but there needs to be time for people to actually get their heads wrapped around what's going on and how they can leverage all of these new tools to create benefit as opposed to just be compliant with some date that's been set. And so I think the last couple of years, a lot of the gains we've made from a tooling perspective have been driven by quite aggressive regulatory timelines. And so now we have all these tools out there, these timelines continue to crank along, and there really hasn't been time for a lot of individuals to sit back and figure out how are we going to absorb all of this and how are we going to change the workflows and the incentives and such around that. So I do think we need to find ways to kind of expand capacity within organizations and create, as leaders, kind of a cultural ability for our staff to try things and fail and learn along the way.
I was going to say, I think the workflow piece is critical there. We have seen in some situations where, although we transmitted the data to the Epic the payer instance of Epic Payer Platform, and so the data is available to the organization, but if the person who's working the queue is working in a different system, unless you do that last mile connection, it might as well not have existed. So I think that's a key component. I do think on the data side, I think there's still some work to be done. I talked about the terminology component. There's also a specificity challenge in some cases. There's a completeness issue sometimes, especially if a patient has had care at multiple places. How complete is the data? The other thing I would mention is on the technical side, I know you're giving us a free pass, but I don't want you to. The other thing I've seen on the technical side sometimes is that there are certain processes that are built to be batch-oriented. And if you want to do a real-time anything, and if one of the process steps in that is batch-oriented, guess what? You're not going to have real-time, right? So there are sometimes we run into situations where although 5 of the 6 pieces can in real time communicate back and forth, one of the piece cannot. It takes a batch file. That batch is run every 12 hours, 24 hours, and then it gets passed on to the next step. Then you break that sort of real timeness.
Can we make a solemn vow to eliminate all the batch processing then at some point?
Well,
No.
you've got the group here.
To that point, I think it's a very unique model that Athena's taken, where we actually started as a payer-provider interoperability company, and that we took over a lot of the revenue cycle functions for these small practices. So when you all can't, resolve an address and send an EOB, those all come to one office in Maine. So we get over 100,000 paper EOBs coming to one address every single day. And Athena's taking those and kind of processing those in a very large batch action as we try to resolve why, And so, as we've taken this approach, we try to create a global one experience for all of the users when it comes to these payer-provider interactions. We've taken that into these new use cases. Now we're finding that it's not a matter of trust or questioning. It's a matter of, well, why isn't every payer here? Why isn't what's the next use case that we're going to come up with? And I think there's actually an eagerness to get engaged in this work, but there is a long tail of, I think, tech-hungry kind of payers that are not able to enter the game at the same level. So to lay that groundwork, what we all are doing and must do is create, more of the work that Jocelyn was talking about this morning, of start, really building standards that allow for providers to see that outside world through a single pane of glass, through a single experience layer that gives them access to all the payers, and there's no more gaps. And that's hopefully, right now I see that as a barrier to progress and not having kind of the full payer landscape available and where we need to move.
By the way, I end up with like 50 more questions that come from this. I do want to just share one intrusive thought that came as I was sitting here. My wife told me to not wear these socks, purple and white socks. She's just like, look, it's just overkill. And I thought, no one's going to see the socks. And then here I am on stage. So it matches the shirt. Like, that's my argument. But just know, every once in a while, even grown-ups have those intrusive thoughts of. By the way, I just want to make sure you're awake. Post-lunch interoperability discussion. So let's talk about just models that you've seen that enable more effective data sharing. And then maybe a secondary question of that, what would need to change across the industry to help those really scale that success?
I think, the staple answer there is going to be standards, but I think for me, and, I think maybe some would disagree, but, TEF got that National Interoperability Framework. I think what that did for data sharing, at least for the Meditech customer base, is that it provided more access and more connection points than we ever had before through those QHINs. But now what we're doing is taking that data and actually putting utility around it, because you can have 100 connections and say that you're interoperable, and that's not true because you're not using the data you're getting. So a framework that allows for data sharing that's level, right, and that's equal, gets you access, and then it's incumbent on the vendor to put that utility behind the data you're getting.
I'll go with capitation. So I think where there's value-based arrangements, it's always been the easiest to get the data moving, because you can start to talk about real alignment here. It's in everyone's best interest to cut admin expense. That equals more profit for both parties. So if you take it all the way to the extreme and you say kind of a capitated model, maybe being a little glib, but I think that would single-handedly eliminate a lot of the economic alignment challenges that we're talking about. We would still be left with the technical, but I think there's a lot of resolve to solve those types of problems when it impacts flow of funds.
Yeah, Sumit, go ahead.
So a couple of things. On the buy-in and trust side, I think in part there needs to be a governance process with participation from everyone. There have to be rules of the road. There has to be a grievances process as part of that. I think the other thing we'll continue to feel a healthy tension, and I think it's a good thing, which is you don't want to reinvent the wheel. So standards are great, and all things being equal, better to be standards than not. Every once in a while, some groups are going to want to run ahead and do something that goes beyond a standard. I think that's okay because it leads to innovation, but I think it's just equally important to then make sure that that work comes back into the standards process, because ultimately, otherwise this becomes very intractable to do. And as that as that's done, I think that some of the work you're doing with Points of Light is, I think, very helpful too, because it's not just a technical thing. It's a sort of show how it's done. What was the change management aspect? How did you inspire people, right? Like I heard this phrase the other day, don't manage change, inspire change. What did you do in order to get there?
And Sachin, did you?
Yeah, just a quick thought to build on it. I agree on sort of the economic models and that being a part of it. From a technology side, if you orient around certain workflows that, just to keep it generalized, like anonymize the data, if you will, at the right level, and then I think with more and more adoption of different AI agents, folks can develop them very quickly. It's actually a means through which you can start to collaborate and share that data in a way that is much more comfortable and still allows you to get the work done between a payer and a provider or whatever set of organizations you're thinking about. So just a quick point there in terms of using that technology capability. Great.
So if I could just push on that a moment, because I think part of what we're all kind of hitting on here is that when there isn't trust, we have to come up with all these workarounds. And another way to look at that is that we're just introducing more inefficiency to try to solve for this fundamental lack of trust that exists. And so I was thinking about this question of trust because it just keeps coming up over and over again. And it seems like we're kind of expecting that, we're talking about trust as like, I don't trust the payer or I don't trust the provider, as though it's, kind of the other side of the equation. But I think the reality is there's a lack of trust intra-organization as well, like top to bottom. And it feels unlikely that we're going to solve this kind of lack of trust issue between organizations if we lack it internally. And what was making me think about this is I watched an HIM department at a provider organization processing prior auth requests, but and they were so worried that a denial later might come back to personally impact them, they're screenshotting and printing and scanning and indexing kind of information completely out of their system just to make sure they had proof they'd done the work, right? And so if that is the people in your organization who are tasked with doing the work and they have fear that their own organization doesn't trust them, it seems very unlikely that we're going to solve this much harder problem of trust. And so to the question of how do we get this to scale, if we're not going to move into a fully capitated model, we're not going to solve value-based care because I still don't know what it means actually at the moment. So like the structural problem to solve has to be how do we put more trust into our respective organizations that over time now start to change the culture of medicine in this country and then allow trust to exist between organizations. So maybe a little more philosophical, but kind of where my head goes.
I think that is interesting. We assume trust within an organization. Like, look, it's between organizations we have to figure out, but you're exactly right. Even within organizations, we have to figure out how to get aligned first. And just two things. I've been talking to a lot of provider leaders about the administration and what's happening with the administration, how that impacts them, both good and bad. And these are fascinating conversations. One of those that's come up is, we talked about TEFCA. As you change ONC and how that kind of folds into the government and how that gets funded, I've been asked by a number of people, like, how's that going to impact TEFCA? I don't know if anyone needs to answer that, but just an interesting question that was posed. And then also another question that was posed of how much does government need to regulate in this space to kind of give us a path versus how much can we work together to create a path? So I don't know if any of you have a quick thought on either of those, but those are things that have come up in the last couple of weeks from groups like you.
I mean, I don't know if I can answer your entire question, but I will say that
if you could, that would be pretty awesome. Sam.
In the last 3 months, we've moved 3,000 of our customers to TEFCA, and we're on a path to have it all done.
Yeah.
Of every single one that can qualify at this point on by the end of the month, because we actually see it as better than the alternatives at this
Right.
point. We think it's getting us to at least a higher plane of kind of a low bar. Would love to see it go farther, but it will unlock something really important, which is the individual access service, which is not available on Commonwealth Care Quality. As a patient can gain access to their own data that was already only available to providers. So in that way, that's a very large change and kind of groundswell shift from a paradigm that this country had, which is only your doctor can get access to your data. Now, as of now, patients that are in the Athena system now have access to their data. The infrastructure around it will be built over time, but I see this train as continuing to move steadily forward, and TEFCA, is part of what's advancing it. And it would be really hard now, I think, to take a big step to the left or to the right. There may be opportunities to improve it, make it more efficient, make it more ubiquitous.
That's what we expected from here, but there's just a lot up in the air. Yeah.
I mean, I've had these conversations even with, some of the health systems that we support at Meditech, and I don't think TEFCA is going to go away. And I think TEFCA, what it did for us is it built the trust framework, and it provided access to patient data for the purposes of treatment, right? And we built upon that data, in that we put utility around it, right? So ultimately, when you're accessing data that came from TEFCA, you essentially almost have a national patient record, because ultimately Athena's participating, Epic's participating, Meditech, et cetera. And now that you see the value, or a care team member sees the value of that data, we just need to now augment it with data from the providers, right? And kind of build a bit more complete story.
Yeah, just so +1 for TEFCA, first of all. I agree with everything you guys said. And then, similarly for us, 100% of our providers in U.S. are interoperable using Care Quality today. I think something like 80% have either implemented or are just finishing up the implementation of TEFCA, and by the end of the year, we expect everyone to be done with that. And then within that, of course, the next level of detail is what use case. So there's treatment, there's patient access. And for patient access, there have been alternative means too, right, through portals as well as EHI export. And I think this will become one more useful and helpful way of getting that. And then the next would be payments and operations. Like you, I had also heard, and I was quite worried actually, would the administration just get rid of ONC and get rid of TEFCA? So I hope that does not happen.
Yeah.
Those rails are going to be very, very helpful. The other thing on the sort of the financing cut, I am quite worried about, will there be cuts to Medicaid financing as an example, and what impact might that have on all these efforts?
Yeah, that's sort of a big elephant sort of hanging out there, for sure. Dan?
I was going to go to the one part of your question about, should the government do more or less regulation moving forward? I would love to say less, but I also think it's noteworthy that over the last couple of years, it is regulation that has driven so much of the advancement we've had. So I'd love to say that the market just will solve it, but I don't know that we have proven that. So I guess maybe it's like a call that if we can figure out how to drive more market-based solutions amongst people in this room, then I think we earn the right to say, give us some credit that we're doing this, and maybe slow down some of the prescriptiveness of regulation and allow us to do this in a way that is investing for the future and building infrastructure that we know we can scale against. Because my concern when we're doing regulatory driven is it's really kind of very brick by brick by brick, and it lacks a lot of cohesion. And so I fully expect that we're going to absorb a lot of our kind of investment dollars that we have allocated for interop, and we're going to get to the end of that spend, and we're going to say, wait a second, this isn't exactly what we want, but there's no more money to keep building it, and then we're going to have to wait for a whole new life cycle to go through, and that is what scares me the most, I think. So I guess, yeah, let's all make it a market-driven.
I think there needs to be a desire, though, especially from the vendor community, to continue to build and capitalize on those investments. I agree with you that the majority, from my perspective, interoperability gains that have happened in the last 10 years plus is because of regulation, right? But it needs to be the right regulation. At the time, a number of us here are guilty is that, we're coding to meet the regulation, but not really the intent. And I think TEFCA is great but a lot of times we're still exchanging CCDs, and everyone knows you don't want to read those things, right? So if we continue to kind of build on that investment and now maybe go Fire first in some of these payer provider integrations, maybe leverage Fire for real-time data, and we continue to kind of build on that, that's essentially how we would further kind of adopt health IT without having the government tell us we have to do it.
All right, so let me take a little bit of a left turn here. So we just talked about how the government's going to impact this. Maybe there's Medicare cuts sitting out there potentially. Is the financial pie getting smaller? And if so, what do payers, providers, vendors do about that?
I sure hope so. So, I mean, going back to my why, if the pie isn't getting smaller, then we have an accelerating problem with affordability. So somehow, depending on which pie you're talking about, like we do need to shrink it. And so, you know, in my view, the right answer is to take a hard look at, you know, who sits in the middle that is currently siphoning dollars out of the system and figure out how to eliminate them, so that even as the pie holds steady or shrinks, payers and providers can actually increase their profitability because they're finding new efficiencies and eliminating kind of the waste in the middle. Like somehow that has to be the answer. And so, yeah, I think it's a hard look at where the dollars are going now that are not into the payer and the provider.
Yeah, so don't be afraid of that. Lean into it. Like, let's go cut out those inefficiencies.
I think you have to. I mean, I just, if it isn't, we're going to have something much more catastrophic that happens at some point. So
Thank you, which is why we're here. So thank you for summarizing the goal here. Sachin.
One additional thought, just from having worked in a payer organization as well before, is there is, and this almost goes back to like the second question of like, what are the things we need to do? There is from afar, I will say, I've not worked in a health system environment, but from what I observed from our customers there and those organizations we partner with, I think in both cases, it is fair to say that there is a level of sort of brute force work that just needs to be done. Put plainly, like there's 20 different systems. We can wait for the perfect, like elegant AI LLM solution that'll go in and read it all and perfectly summarize it and drop it into 10 buckets for you. Or you can just say, we've, for the last 10 decades, 10 years talked about doing it. Now let's just sign up for the next 2 years. Here's the list of those systems, and those internal IT systems. One by one, we're just going to staff and brute force change them and force them into what we need to, so that it's readily available for everyone inside. And I don't think it'll be surprising how much of that extra overhead goes away. And it's a harsh thing, right, to say there's like people's roles and jobs in those settings, but that's what's going to need to come out, because I agree with the opening comment, which is like there is pressure overall on the system to reduce costs. And we know there's a lot of bloat in just these like, to use kind of the Office Space joke, I take the papers from here to there type of roles, right? And I mean it with respect. I know that folks are well-intentioned and want to do more with that, so let's up-level what they can do and make it more efficient for everyone so that the dollars can go to care delivery.
And it does feel like 10 decades we've been talking about it. So like hopefully we can make some progress. Yeah, please.
Yeah, I was going to say, even when we started working on Payer Platform, we asked our providers, what is it that you would like to see happen? And save on. And then we asked some of our early payers. Nancy's there. Nancy's awesome, by the way. And you were our first sort of collaborator on this. And we got the list from our payers. And then turns out there's a pretty good overlap. And that overlap probably leads to 20 to 30% overhead on both sides. And so I agree with that, everything that's been said. And I think that would be an important sort of area to focus on, and I do think we should be continually flipping this question from, regardless of what's happening to funding, where is time and money and energy being spent on things that are not net new value add?
Yes.
Yeah, I would just add, I think this is where things are going, is trying to attack those potentially with, voice and AI automation. And we're moving from, an agent calling up, a payer to follow up on a claim, and then the agent on the other side picking up and looking up things in a portal, to having a bot do it, right? And use a human voice to call the bot on the other side who might actually be answering with a human voice automation. And so you have bots talking to each other, looking up system information, just doing the same work they're doing today. And to that pie, right, yeah, is that going to cost more or less? I think it probably ends up costing about the same unless we fundamentally think differently about, these broader kind of environmental issues around, the way that we pay for care, the way that we incentivize care, and the way we align around incentives in a value-based care world. And I know this is kind of like why we're at this conference and what we're all working on. But I would hate to be here 5 years from now talking about how our bots are working better together. We gotta be thinking differently.
Yeah, battle bots. Yes, Sumit?
Yeah, I was going to just say, just on the AI thing, certainly there are some new doors that AI is opening, right, for providers being able to just directly talk with patients and have ambiently listening AI help with writing of the notes. I think that's a good thing. I think in some cases using AI today to solve a piece of a solution that ideally is not even a problem, does not exist, but since it exists today as a workaround, I think is okay. But I think in the end, if we're just doing a battle of AI versus AI, only the hyperscalers, the cloud providers, they make money, and everyone else is just, writing checks.
Right.
And that would be very, a shame.
So I have two more questions, and we're going to get to questions from all of you. And I can't wait to see what questions you have for this group today. So the first one I want to ask is, what do you think it actually looks like in 5 years? Because I mean, 5 years is far enough out that we can't quite see it, but it's close enough that we could almost touch it. How big of a difference does AI make? Like, what do things actually look like between the payers and the providers in 5 years?
I'm gonna channel optimism. So, I mean, I think there's like a very real scenario where it doesn't look a whole lot different because we could have had this conversation 5 years ago, and it's changed and not changed. So that aside, I think like the positive would be there's a lot of momentum around prior auth and payment integrity right now, which I think is really highly intertwined. And so I'd like to believe that we find a way to do, as you just mentioned, Sam, which is break medical necessity apart into different components and really rethink the whole kind of adjudication and process. And in doing that, which is facilitated off of clinical data, like if we can start to think about using clinical data to adjudicate payment decisions as opposed to using administrative and claims-based data kind of writ large, it does create kind of a whole new payment infrastructure. And it sounds a little wild. I know, Blue Shield of California has been trying to figure out how to eliminate a claim and pay with clinical charts for 5+ years through a lot of iterations. But I think it's indicative of this desire that we all kind of have to say the claims are batch, the claims lack context. Like all of these processes we've created are to address issues with the infrastructure we have. So if we can move past it, which I know this administration wants to do, I think a lot of people in this room want to do. And so if we can get there over the next couple of years, I think that would usher in a fundamentally different looking system.
I think that optimistically in 5 years, we've solved the kind of trust element between payers and providers. I think technology continues to advance in AI, even if just implemented internally within a health system or at with a payer, is going to force us to improve the data quality issues we have, because when you're trying to move that data up to a large language model and it's not great, well, it's not going to work great. So, we're looking at how to manage the data mapping and whatnot. So I think that in addition, I think we're going to look at a more complete patient record that's comprised of not just data from health systems, but data from payers as well. And technology like maybe AI is going to help surface insights and allow clinicians to better understand what they're looking at.
Yeah, one practical way I've now talked to some folks on both provider and payer side, but especially on the payer side, what they're doing is they're taking all the stuff they have today published as PDFs, and they're using LLMs to digitize them and turn them into sort of discrete artifacts. And then those will become foundational to ultimately, for example, with prior auth, the most ideal way to do this is to digitize that and make that available right in the provider's workflow, right? Like, ideally, prior auth is an instant thing. Right in the provider's workflow, you either know you can do it or no, you can't. And if you can't, maybe the second question is you need a more, higher level of specificity to say what you need to do. But it ought to happen right then and there, as opposed to the way the process works right now.
Just a quick thought. I think the cost pressures are going to force this action, to Mike's points, and I think that actually a lot of businesses have been out there that have been utilizing some of the technologies that have been referenced, and so you're actually at a point now where many more providers and payers are actually testing all of these. And so I actually think in 5 years, you will see a markedly different adoption of technology to drive these efficiencies.
Yeah, I think in 5 years, maybe in 1 year, we're going to have some of these things pretty near solved. And I will say that we may be less reliant on strict implementation guides and specific specifications, and start to look at our faxes a little bit differently, because we'll be able to pull out all the information and context we need from highly unstructured, highly just not the way that we like to do it today, but in the future we'll have tools that will allow us to really pull information out and label it and codify it and bring it into robust models that can pull out the right information at the right point. So with that as a tool, we'll be able to bring, to Michael's point, like a full record together and use it for the purposes of decision making and process improvement. And it's coming very, very quickly, and it will solve a lot of use cases.
Am I allowed to throw in like a hypothetical here, and not even?
I was just going to add an amen to the end.
All right, amen. But I was sitting, at Meditech, we kind of have this, I don't know, maybe monthly, biweekly meeting where we talk about where all AI is kind of introduced into the HR, and we're measuring the example you just used, like the bot-to-bot thing for claims denial. I sat there and I'm like, why are we investing in technology to have two bots talk to each other when you should just have a back-end process doing this? And no one knows.
Okay, so the last question is this. What's the one thing you wanted to say today, but I didn't ask the right question, you didn't have enough time? Like, what is the one thing that you were hoping to share today that still needs to be shared?
To be powerful is to have the freedom to be generous. So don't be shy about allowing your partner on the other side to maybe get more of the deal in pursuit of advancing the goal.
Great. Thank you.
I would just say that as we continue to invest in solving these problems through technologies and the work groups that we're all participating in, just to keep in mind that, Middle America, the community hospital, they're delivering care, and they might not have access or the capabilities that these larger systems and payers do. So when we're coming up with models, we should keep those folks in mind.
Models for everyone. Great.
I just learned this phrase from my daughter, LFG, which I'm not going to spell up here. But yeah, it's just time to start executing.
LFG sounds like a T-shirt for next year's summit. So, okay.
Yeah, I think you generally covered it. I'll just do +1 on Mike's.
I just want to assume that's exactly right. I just watched Welcome to Wrexham, the first episode. Are you guys there's just a level of kind of desire to see a team succeed from the owners of that club that just inspire me in my own daily life to say, how can I think bigger? How can we make the big bet to move these things forward and not get hung up on the little incremental changes? So I just encourage everyone to just bet big on what we can do here, because I really do think we can solve these things in ways that we couldn't before in the next 1 to 5 year horizon.
Perfect. Thank you. So we're going to go to questions, but first, one last intrusive thought. I just got a notification from my phone that my son, who's 16, just Venmoed me $100.
What?
So that makes me wonder, did he break something? Did he, what? And do I need to text him right now and say, what happened? What's the deal? Okay, so what I could do that in front of everyone. Hey, buddy, you're on the stage. What happened? By the way, I have to add to that, he just turned 16, just got his license. I handed him my keys for what I told him is the best moment of your life, your first drive solo. Like, which is like the freedom of that moment is incredible. So he's going to the grocery store, which is literally like 2 minutes from my house. He leaves, comes back, brings in the bag of chips that he bought, and he said, "And Dad, I may have knocked your mirror off." So that was in the garage, backing out. 3 seconds into his first drive ever, knocked the mirror off the car. So anyway, those are the kind of great things that happen in our house. So questions, not about the car. Mike, do we have a, Sam's, we're going to bring up a microphone for you. No, that's his older brother that rode his bike 2 years ago. So
Is that when you showed up with the cast? Michael Marciano with Sutter Health. So one of the interesting concepts that we touched on very, very briefly was around the patient. And I'd really like to figure out, today the burden on this exchange, a lot of it tends to land on the provider's shoulders to figure out where, what, who, when, and how to get the right information to get to the next step in care. And I'm wondering what your thoughts are on trying to actually move to more of a patient-mediated exchange where the patient's at the center, trust no longer becomes an issue, consent no longer becomes an issue, and they have the ability to direct the information they need to the right place. And I think as much as patient access APIs give them access to their data, making that actionable and putting it in the right spaces in the workflows that you all are talking about isn't something we talk about very often. And I'm just trying to understand, is that a technical challenge? What would empower a patient who's most interested in controlling their care to be able to allow for that to happen in what we talked about, which didn't talk a lot about patients today?
Yeah. A couple of things that quickly came to mind, and then Sumit has way more patience on his platform, so he can kind of give us some thoughts. But in many ways, there's another way to frame that is like we're almost putting burden back onto a patient who's in this moment of crisis and asking them to be able to, advocate for themselves very effectively, which I think there's a lot of evidence is not really what happens. And so while I think it's very important that we have those types of capabilities, I also think it's incumbent on all of us to make sure we're not dependent on the patient doing that for us to be able to serve them well. So that's kind of one quick thought. Sumit.
Yeah, a couple of things. I think there are certain things we can do and we should do to give especially more transparency to the patients. So for example, price transparency aspects of being able to get more accurate, more timely, sense of what the pricing will be. And then someone mentioned earlier today that when that happens, they also tend to pay earlier and everything just works better. I do agree with Dan. I'll tell a bit of a story. My daughter goes to college in Boston College, and our primary care is in Madison through group health, but she also gets insurance through, the college services, which is, I think, ultimately a United coverage. And she had an emergency visit. She was not really in it when she was asked for her insurance. She gives her primary insurance. Somehow it didn't go through. Maybe it was mistyped. The person says, "Do you have any other insurance?" She says, "Oh, yeah, I have group health." So she gives her group health insurance. She gets her care at Mass General. 4 months later, we get a bill. She gets a bill, her name, for $10,000. And oh my God, you should have seen just the tears on her face. And in that moment, there's nothing about transparency that would have helped her, right? In that particular case, it shouldn't have come to that in the first place. So I agree with you, Dan. I think there are certain things that we can do where I'm all for patient transparency and advocacy and agency, but I think there's certain aspects of how everything works today that the last thing I want to do is now put that on patients because they're already struggling to deal with a lot of things, and they are in some ways going to be very overwhelmed with this type of complexity.
All right, other questions?
Glenn Rayleigh, Humana. One of the things that, and I'm certainly with you guys. I'm all in. I work with many of you today and many of you all in the room. When I think about the analogies that were used this morning in terms of entertainment or banking, we are all trying to make the system better, right? But the banks, when they made everything better, wasn't thinking about PayPal, right? They weren't thinking about Venmo. The taxi industry wasn't thinking about Uber. And so it's not whether we can change. What I think about is, or my question for you guys is, what is it that you think is the most likely way that the industry gets disrupted by any one of the players, right? I mean, so whether it's a payer, the providers, or the software vendors in the middle, where's that disruption going to come from? People are trying to disrupt already digitally, right? Be a digital plan or be a digital this, virtual care. But I still don't think we've hit that sort of tipping point where we hit that true disruptor.
One of the, I don't know the answer, but one of the trends that I'm really interested in and I'm watching closely is, for how many years have we heard employers aren't going to accept another rate increase and they accept it? But, at some point that won't be true. And so this trend for employers to do more direct contracting with, smaller provider organizations, the ASCs, the, infusion centers and whatnot, but almost kind of taking this very large percentage of patients who drive so much of the dollars into the system and now saying, through a combination of different technologies, we can go and self-fund a much smaller population of people, and we, through direct contracting, can avoid the system, frequently. And I'm not going to use a TPA from Abuka because it's not aligned with my incentives. And so you pull the employer book out, and this whole system looks a lot more fragile than it already does. So that's probably where I'm kind of most attuned.
I do think, just call it the non-employer side, but everything else, I still believe that there is a path if you knock out a significant amount of cost. And if you just look at the case study of maybe the bellwether businesses that really kind of 2019 through 2023, before all the MA adjustment and whatnot, that really grew and were showing at least care margins that seemed sustainable over the long run between both payer and provider. I still believe that there is a path there because a lot of the extra costs that led to them being sort of like entities that ultimately weren't sustainable, if you had like cost spikes in certain months or certain quarters, can be knocked out and offset so that you're more resilient through the adoption of what we've been talking about here. So put in a different way, an organization that can take on the sort of full dollar or the 85 cents, whatever, from your perspective, and then manage that effectively is probably still the viable way because you've got a lot of the sort of infrastructure for those handoffs, especially I think in the advanced markets where you've had capitation and things like that for a lot of years. Recognizing the density of like network coverage and everything is different than it might be in some other settings. There is a way to get that financial equation to work, which ultimately is kind of the underpinning of like, okay, we all feel like we can sustain it. Physicians can be compensated at the right level, and then you kind of go from there. So a lot of that excess, call it 20-25% cost, should be able to be knocked out, would be my thesis at least.
Could I go on a bit of a rant on financials? I feel like we as an industry somehow have an inferiority complex to financial side. I think it's true that ATMs beat e-prescribing by a couple decades, but last I checked, I can't start a loan application on one bank and have it complete in another. If I switch banks, my records don't come right. So I think in some ways what we've done in healthcare is a lot more than what banking has, while maintaining a lot more level of complexity. So I just wanted to say that, number one. And number two, I do think, as everyone has said, I think there's a good roadmap, and I think I just want to roll up the sleeves and execute.
Great. Other questions, please?
Nate Fitton, Chief Medical Information Officer at MSU Healthcare. I'm a medical provider as well. Sam, your story about the patient access or lack thereof of providers to see things, hit really home, right, as I take care of my patients. And so having some of the biggest players up there within the EMR world, what do you see as the biggest barrier to this interoperability of EMRs to speak to one another? And what is that biggest barrier? Is it tech? Is it policy? And what's being done to break down that to allow communication across those fronts?
Yeah, if I could speak to, I'll tell you the specific example I had was two large EHR companies that already actually had the tech in place to do exactly what was needed, but the one company didn't turn it on because they were afraid the other one would see their patients and try to poach them from their system. It wasn't a payer to provider thing, it was a provider to provider, highly competitive, directed network. If I can get you to see me, you'll take my insurance as well. And there's a lot of this just distrust of what you'll do once you have patient data beyond how you treat them in the moment. So there was no, we're not going to participate in the HIE. No, we're not going to turn on the feature in our EHR. So that's, I mean, of one example. I don't know how, I can't speak for the entire market, but I know specifically that was the thing. And that's one of the things that now when I advocate, with customers and things, it's like, turn it on. Like, don't hesitate. And that's why, at Athena, we have a very progressive stance on always enabling interoperability. But that's just one example. I'm sure others have other thoughts.
Yeah, I think that's a common example.
Yeah, as I said, I think 100% of our customers are able to interoperate. I asked for the latest stats, anticipating that question. In the month of April, we were on average doing 23.6 million record exchanges a day. And about half of those are with non-Epic sites. I think Athena might be the biggest actually trading partner for us. And then we do it with others as well. In fact, a bit of a story, if I could, when we were first starting to do this, when we first created Care Everywhere back in the day, one of the providers who signed up, they were one of the two initial providers to sign up for it, many years later said that what happened was my CIO came to me, gave me a bunch of paper and said, sign this, so I did. And had I known what I was signing, maybe I wouldn't have. So I think there was sort of, I do think generally speaking, though, we've come far from that. I'm not going to say that there's not a single provider who might think like that, but I don't think that's the issue. Otherwise, we won't be seeing the type of record exchange we're seeing today.
Yeah, sorry if I could just respond. I think where we're at now is actually, in the scenario that I have, the data would be there, but I still don't know if the nurse or the doc would have actually pulled it up or known the nugget that was really relevant to that experience and why that patient had the extra complex scenario. And so what you're seeing is now, okay, ubiquitous exchange, tens of millions, hundreds of millions of transactions per month. Transactions aren't really a measure of success. It's really, what is it? And I think doctors, I'm not a doctor, but I understand that when you take a note, oftentimes you leave kind of that note at the end, that discharge summary, the progress note, that's meant to be kind of the baton to the next doc, or it's the thing that you pull up the next time you open up the chart. And that thing is the last thing that gets codified in this exchange of information, and where we're seeing like the power of LLMs and actually discovering what it is in that note that's going to be relevant to the next venue of care. And so we're all experimenting this stuff, obviously, but when I see the results, the early returns from saying, okay, we're getting hundreds of millions of these in a 6-month period. Like, can we start sampling and understanding what's in there, what's going to be valuable to docs, putting it in front of docs? We're seeing like the data that's already there that we've never been able to truly make valuable for docs. I think as of like the last few months, we're seeing docs like eyes pop open. Wow, that's been there the whole time. And you're saying we can start to make interfaces that bring it to the top. So, I'm not trying to give the roadmap, but these are things that are right on the cusp of, I think, getting a lot better.
That progression has been, by the way, fun to see. When we first did this Care Everywhere thing, people said, don't put the outside stuff in chart review, interspersed with my stuff, because I don't know how the liability would work, right? Wanted separation. So we programmed it like that. And very soon they said, well, this is kind of silly. Why wouldn't you show it in line? So we're like, okay, we've sort of changed it, and we started showing it in line. And I agree with you 100%. I think the ability for LLMs to take a lot of data and then summarize what might be helpful, including information that might have been received from outside, I think it's going to be a game changer.
I also want to just kind of pull it back to something else, which is you asked whether this was technical or something else. And I think it is both. I have, in the last couple of years, I moved states, and I had to go and get immunizations. And even though My immunizations have been administered at an organization on an EHR, and I was getting my new immunizations in Michigan on the same vended EHR. None of my immunizations came across because it's across state lines, and so why would we ever share immunizations across state boundaries? And so I had to pull up, my portal and manually move it all across. So my wife's a clinician, and she can't use the problem list because all of the records that interface in keep overwriting all the problem list work she does to clean it up. And so this idea of problem-oriented charting is kind of cute, but not practical for her. And so I think, just to kind of bring it back, we talk about a lot of the really cool stuff we're doing, but there's some like pretty straightforward blocking and tackling items that continue to be holding us back, and they're more than technical.
All right, one last question. Please.
We've talked, great panel. I would have loved to answer every question. But when you talk about all the exchange and submit, I know the 20, that very amazing numbers, right? But the most of that number is the treatment use case. I mean, by far, right? So I think if we're going to make a difference in the next 5 years, I've been trying to be on a soapbox to say we've worked on treatment for 10 years, and we really have treatment in a really good place. But if we want to make a huge difference, and if we really want to go the next mile, I think we've got to put that kind of effort in the payment and operations use cases. Yeah. And I don't think we'll make a whole big change on everything until we put the kind of effort into payment and operations that we put into treatment. So I'm just kind of interested to know what you all think or how you're approaching that right now. On the national scale, it's just not there, right? I mean, QHINs, only one QHIN supports payment operations, so it's a problem.
The way I've always kind of thought about it, I'd be curious for your take, but on treatment, we all know it's the morally right thing to do. And so I think back on those early kind of imagine if meetings that we had, and it was kind of like always somebody shows up in the emergency department and we don't know who they are and whatever. It's like easy, we pick the use cases that are really, really hard to say no to. And now with payment and operations, what we're talking about fundamentally is a whole lot of big businesses that don't have a business tomorrow if we really do this the right way. And so we've got to go to war every day to kind of make the case that, we're going to keep moving it forward, and somebody is going to be not happy about that. And so it's not really an answer other than like, yes, I agree, but I think we have to acknowledge that there are people not in this room that are very resistant to progress, and we need to find a way to make it anyway.
Yeah, I mean, be as that may, we gotta do the work. Hopefully, also learn from, the lessons learned from the treatment side. I believe we'll go faster than, 10 years. And I do think TEFCA will provide very helpful rails for that.
Having been at two organizations, one was really struggling with providers wrapping their head around, meaningfully trading information with payers, and one that has a very high level of trust and actually gets the right to play that role on behalf of their providers. And Athena has created essentially ubiquitous connectivity with certain organizations where every Athena provider is opted into this type of exchange. And what's really powerful is when you see the returns. And so I think seeing kind of the value that's generated from the exchange has led to that kind of positive sentiment and flywheel effect, where our payer partners who live up to what they're trying to accomplish, and we can showcase the value to the providers. It really does engender trust and a desire to kind of work even more along those lines. And I think if more and more we could do that at an industry level, we could prove out to the entire market that there's, it's not, going back to their very first points, it's not that scary thing. It shouldn't incite fear. It should incite a significant amount of excitement and enthusiasm about lowering the cost of care because we're doing things in such a streamlined way.
All right, great questions. We're out of time, but thank you, everyone. And can we give another hand for our panel for being here and their candor?
I think we'll end with Sumit's LFG.
LFG.
I learned it yesterday.
That's good. It's perfect.